Welcome to the Explainer. Today, we're going to break down a framework for diagnosing a whole new clinical challenge, endocrine immune-related adverse events, or irAEs. With immunotherapy becoming so common, having a systematic way to think about these conditions is absolutely essential, and that's exactly what we're going to walk through.
And let's kick things off with this really crucial point from Dr. Melissa Lechner. This perfectly sets the stage for why we're here. These are not your typical endocrinopathies. They have a totally unique pathophysiology, they present differently, and they really do require a specialized diagnostic mindset.
And just to give you a sense of the scale of this new challenge, get this. Immune checkpoint inhibitors, or ICIs, might be an option for about half of all cancer patients in the US now. So yeah, this isn't some niche issue anymore. This is quickly becoming a core competency for us as endocrinologists. So here's our roadmap. We're going to start with a quick primer on how these drugs actually work. Then we'll walk through the diagnosis for the big three events, that's thyroiditis, hypophysitis, and adrenalitis. And then we'll wrap it all up with the key takeaways you can actually use in your practice.
Okay, first up, a quick primer. Really getting a handle on the mechanism of action is key, because it explains why these specific endocrinopathies happen and how they're so different from the spontaneous ones we're used to seeing.
This slide is great because it shows you the two-front war that ICIs are waging. So over here in the lymph node on the left, you've got anti-CTLA-4 antibodies. Think of them as removing the first set of brakes on T cells. Then on the right, inside the tumor itself, you have anti-PD-1 antibodies that stop the cancer from shutting those T cells back down. It unleashes this incredibly powerful immune response, but sometimes that power gets misdirected at healthy endocrine tissue.
All right, let's dive into the most common endocrine irAE, thyroid dysfunction. This is the one you are absolutely most likely to see, and luckily, it has a very characteristic pattern.
Timing is your first big clue. This is a destructive, painless thyroiditis, and it typically pops up pretty early, with a median onset of just 4 to 6 weeks after a patient starts on an ICI. What's interesting is that because oncologists are already monitoring thyroid function so routinely, a lot of patients actually get picked up when they're completely asymptomatic. But for those who aren't, you might see them come in with those classic thyrotoxic symptoms at first, which then eventually give way to the more familiar signs of hypothyroidism.
So the whole diagnostic process is really about tracking the trend. It all starts with that routine monitoring of TSH and free T4. What you're looking for is that signature biphasic pattern, a quick, transient thyrotoxic phase that eventually just burns itself out and converts to a permanent hypothyroid state.
And listen, this is a huge practice point. Unlike with Graves' or Hashimoto's, you can pretty much set aside the usual antibody tests and uptake scans. They're often just not helpful here. The diagnosis really just hinges on watching that classic biphasic pattern play out in the TSH and free T4. Simple as that.
Okay, next up is hypophysitis. This one is most common with anti-CTLA-4 therapy, and the biggest danger, the thing you've really got to worry about, is the potential for secondary adrenal insufficiency.
The timing for this one is a bit later than thyroiditis. You want to have a much higher index of suspicion for hypophysitis somewhere around the 9 to 12-week mark after a patient starts their therapy.
The symptoms here can be so frustrating because they're non-specific. They often overlap with the cancer itself or its treatment. But you've got to be on high alert for a new onset headache. That's a red flag in about 60% of patients. And critically, you have to be vigilant for any signs of an adrenal crisis, like hypotension and confusion.
Your entire diagnostic approach here has to be driven by clinical suspicion. If a patient on an ICI comes in with these kinds of symptoms, the first, most important step is to check the adrenal axis with a morning cortisol and ACTH. This is a can't-miss, life-threatening situation. You'll also check for central hypothyroidism. And what's interesting is that while an MRI might show an enlarged pituitary, it's actually not required for the initial diagnosis unless you have specific neurological concerns.
So this really gets to the heart of the challenge. ACTH deficiency is the most dangerous thing that can happen, so you have to rule it out. And when you look at the thyroid, that classic sign of central disease, a low free T4 without that high TSH you'd expect to see, tells you the problem is starting up in the pituitary. All right, let's shift gears to primary adrenal insufficiency, or adrenalitis. Now, this is much rarer than hypophysitis, but it is equally critical to diagnose and fast because of how severely these patients can present.
The timeline here is actually very similar to hypophysitis, clustering right around a median of 10 weeks after therapy starts. And that means you can't rely on timing. You have to rely on the biochemistry to tell them apart.
And again, we're seeing these nonspecific constitutional symptoms. The key difference here, though, is the sheer severity. I mean, it's pretty astonishing, but in some studies, up to 90% of these patients present in a full-blown adrenal crisis. You might also see those classic electrolyte changes, like hyperkalemia, which, of course, you wouldn't see in secondary adrenal insufficiency.
The diagnostic process itself isn't complicated, but it absolutely depends on you thinking of the diagnosis in the first place. When you suspect it, you get a morning cortisol and ACTH. The biochemical signature is unmistakable. A low cortisol with a sky-high ACTH tells you, without a doubt, that the adrenal gland itself is the site of failure.
So, when you're trying to figure out the source of the adrenal failure, it really all comes down to the ACTH. A low or inappropriately normal level points to the pituitary, but a high ACTH, like we see here, is the definitive signpost pointing directly to a primary failure in the adrenal gland. Okay, let's pull all of this together now and really synthesize it into a clear comparative framework that you can actually apply in your practice. This table right here, this is probably the most high-yield tool from this whole explainer. You can see the three conditions right next to each other. Thyroiditis hits earliest, and the key is that biphasic pattern in the TSH and free T4. Then you have hypophysitis and adrenalitis, which both show up later, right around that 10-week mark. They're both diagnosed with a cortisol and ACTH, but the key differentiator is that ACTH level. Low or normal for pituitary failure, high for primary adrenal failure.
Now, you might have noticed one major endocrine player is missing from our list, the pancreas. And it is absolutely a critical target, but its presentation follows a very, very different script.
That's right, ICI-induced type 1 diabetes. It's rare, but it is a severe event, and these patients often present in DKA. The way it causes this rapid beta cell destruction, well, that warrants its own deep dive, which we're going to tackle in our next explainer. Ultimately, mastering this new class of endocrinopathies isn't optional anymore. It's about staying one step ahead for our patients in this new era of cancer therapy.